네, 녹화 시작됐습니다.
위에 양쪽으로만 고개 들지 마시고 양쪽 무릎만 굽혀보세요. 무릎. 네. 힘 빼시고 양 옆으로 천천히 벌리세요. 그렇죠. 그러고 계세요. 잠깐만.
위에 못 풀어도
So hello everyone. Today we're gonna have a subcoronal approach IPP, inflatable penile procedure into local anesthesia. The first part is how I do the local anesthesia. I usually start with the pudendal block.
My name is Dr. Ernesto Gerial Jr. and I'm a practicing urologist from the Philippines. I'm actually involved in 5 hospitals in the Philippines, but my 2 major hospitals it's a government hospital. It's called the National Kidney and Transplant Institute, and one of the modern and well-equipped hospital in the Philippines is called the St. Luke's Medical Center.
I'm Dr. Gerial Baloloy. I came from the Philippines, and I'm a vascular surgeon, subspecialized in transplantation. My hospital is the National Kidney and Transplant Institute and Makati Medical Center.
Well, there came a point in our practice that we need to look for something which we can offer our patients who needs help, particularly patients with erectile dysfunctions. We encounter patients with this problem, especially those who underwent prostatectomy, and also patients who underwent transplants. So it came to a point where patients would ask for some help, and medicines only offers a little. So there must be something more. And so someone told me that here in Korea, they're doing a lot of these cases, and there are good doctors here who does it. So we took the opportunity to come and visit and see how they do it here in Korea.
In the Philippines, I think there's no data yet that will tell us how much or how many are needing this procedure. But I think we can tell somehow by the number of patients looking for medical remedy. More or less, you can surmise the number of patients probably needing this procedure. And aside from that, of course, not all of those under medical regimen will be needing this procedure, but maybe a portion of that.
I had one opportunity sometime 2 years ago in 2016 with the same purpose of having to be exposed in penile implant, and I was able to go to Qatar in one of the big hospitals there. The government hospital is called the Hamad Hospital. But unfortunately, for some reasons, I was not able to see too much cases there. So I was only able to see 2, but it was not as in-depth as what I had seen here.
I've attended some, but not of this kind of procedure. Mostly in conventions, the Asian Vascular, in Singapore, in Malaysia, and some other places.
Oh, they're great. Okay, especially for someone like us who is not very much familiar with this, and you see it in the actual performance. For a surgeon, the feeling is great. It's very educational and it's very informative.
So today's case, really great, and we are happy to have that opportunity to see those cases. I've not seen anything like that, so it's a very much a learning experience for us to be seeing these 2 cases and with different approaches to implanting prosthesis.
Well, at first I was surprised. I was surprised that you can do such a kind of surgery under local anesthesia. But probably for us beginners, we would rather do it in a way that the patient is asleep, so we can do it slowly. But of course, for the hands of an experienced surgeon, it would be best to do it under local anesthesia, because you would know that the patient is doing okay when the patient can respond to your questions during the surgery. So for a beginner, maybe I would think twice in doing it under local, but once I gain more experience as we go along, then probably it would be better if we do it under local.
Two things, subcoronal approach and the local anesthesia. These two are what I want to tell them, but ultimately what I want to tell them is there's a whole lot of different patient characteristics. So we surgeons should be able to adapt every single case with a proper method. Today's live surgery case was the reason why he had to have a local anesthesia is that first of all, erectile dysfunction surgery, this is not a life or death situation, right? I do not want to make any other serious complications because of the surgery. So this patient had a lung cancer and he only have one lung left. Okay, so, and he's 77 years old. So having him go through under general anesthesia, it's a whole lot of mess. He need to have a whole lot of different tests to get the general anesthesia for this surgery, and then throughout his mechanical ventilation during his general anesthesia, his lung can be damaged severely. So why making a serious impact in the patient life with something that is not affecting his life? So that is my theory. This is not a life or death surgery, so I want to make as minimal impact as possible to the patient life.
I am a vascular surgeon, and sometimes we deal with patients with erectile dysfunction. Some of our patients who underwent, for example, an open aneurysm repair of the abdominal cavity, some of them develop erectile dysfunction, and I think would be needing this procedure. And some of our patients are chronic kidney disease patients with an early onset of erectile dysfunction. And I think they would benefit from this procedure.
Well, of course, we've been doing it in some other ways in all of our cases. We also do it in other urologic cases. So why not? Why not? I think this is one form of disseminating information, not only for the patients, but for the doctors who can do it as well.
Previously, I had a live surgery at the Taiwan General Hospital there. The difference with today's live surgery is that my center is just doing the perineal prostate surgery, so it is really well equipped and well prepared. All my staffs are well trained, so I really do not have to think about other things than surgery. So, but when I was doing the live surgery in Taiwan, it was a good experience because there was nothing ready, I'll say, because they aren't doing the general surgery, and they are a good staff, but still nothing was prepared well. So today's live surgery made me feel like surgery is not just about one-man show. Actually, it's a team play. I need a good team. Whomever it is, you need a good team to do the live surgery or a good surgery to do the better job. So I guess in terms of that, I had a much easier live surgery than before. But as the patient was a little bit pretty sensitive to the pain, that was a little unexpected point. So that gave me a little difficulties though.
Yeah, that would be great because we've been part of like a procedure like this. In our center, we do a lot of postgraduate convention, and we do give them lectures. And I think participating in this type of activity would be great for a continuing medical education for those who are interested.
So back in the days, we were learning surgery through our photos or articles, I would say papers, right? So surgery is in motion, right? Every single step, even though you take photos, you cannot imagine the steps in between. But by showing it through a video, at the same time, you can explain, you can add your voice there. You can explain why this is going on, why this is important, or how long it takes. So actually, it is not the best form, I would say. The best way to learn the surgery is be at the OR with the surgeon. But still, showing them through a video is by far one of the most efficient way, I would say. One of the most transferable method of doing transferring our knowledge. So the trainees can at the same time. The difficulties with the actual live surgery at the OR, you cannot rewind it. You can only do it in your brain. But in the videos like this, you can watch it several times. You can ask the original surgeon why he did it like this or that. And you can, image train yourself several times with the video. So the benefits of the live surgery, the first one is by far the most efficient way to transfer the surgical knowledge. The second, they can view it several times with several explanations. So I think that's the reason why we do the live surgery videos like this.